All right, I'm going to go ahead and get us started. My name is Alexis Whittam. I'm the Director of Communications for the Colorado Coalition for the Homeless. Thank you all so much for joining us for the August session of our education series. These events generally happen on the third Thursday of most months throughout 2022. We'll be coming back September, October, and November, taking December off. So please continue to join us. Aubrey, if you could go to the next slide. Thank you. So tonight's session is entitled The Challenges of Living with a Disability While Experiencing Homelessness. And we're going to cover as much as we can on the topic. It's a big topic. And we have already some questions from people who signed up, and we're very excited to cover it with our panelists. So I want to start by going over some basic information about the session. Aubrey, if you could click to the next one. Thank you. So in order to be accessible, we have live captioning available. It's a live transcript. You should be able to see a little CC button at the bottom of your screen. And then if you can't see it, hit the more button with 3 dots. And then you should be able to view the live transcript. It might say show subtitle. It might say live transcript, but it should be enabled right now and it's automatically captioning. I'll also let you know that when we put it on YouTube tomorrow, you can also add captions on there. So we're hoping it's as accessible as possible. If you're having trouble getting the captioning on, please write in the chat and let us know. And we have quite a few staff on, so someone can help you out with that. I would also just want to cover our agenda, how we're going to do this today. So some of our sessions are more presentations and some are more panels. This one's a panel. So we have 3 experts who are going to join us, and we're going to have a discussion for about 45 minutes that will lead with some questions we've planned, and then we'll have a Q&A at the end for 15 minutes. We'll also start with a presentation with data on this subject, because we know that people come to us with varying levels of knowledge. Some people work in the sector, some people are experts, and some people know very little. So we always like to do a little bit of data at the beginning to kind of get everyone on the same page of what's happening nationally, what's happening locally with the topic. We are in webinar format, which means that for any of our wonderful participants tonight, your cameras and microphones are off. So you can use the chat feature to talk with each other or let us know if you're having issues. And then if you can please use the Q&A feature to ask questions of the panelists. We're going to do our best to not answer them in the Q&A box, but like I said, instead to answer them at the end. That means that anyone who watches this after the fact also gets to see that answer as we've answered it live. So it's a little bit more accessible to those who weren't able to join us tonight. As I mentioned, the session is being recorded. Just wanted to let folks know that. And we do try to get them up on YouTube by the next day. So if everything goes well, we'll have it on YouTube tomorrow. We'll also have a reply email to everyone who registered with that information. And it'll also have this slideshow with it. So please don't feel the need to take notes, write down statistics in the slide, anything like that. You'll get this tomorrow and be able to have all the information at your fingertips. If you like to be on social media during events, after events, we have the information there. We're doing hashtag CCH Ed Series. The Colorado Coalition for the Homeless is at CO Coalition. And then our other speakers tonight are from Denver Health. So we have Denver Health Medical and the Colorado Cross Disability Coalition. So please feel free to reach out to us. So I'm going to go ahead and turn it over now to my colleague, Andrew West. Andrew is the Housing Policy Fellow for the Colorado Coalition for the Homeless, and he compiled some data that we're going to go over in the beginning to have a broader understanding before we jump into our panel. So take it away, Andrew.
Excellent. Thank you, Alexis. I appreciate the intro. And yeah, I'm going to be giving a brief data overview. As Alexis mentioned, I am not one of the experts. We have a panel of 3 great experts that we'll hear more from. I just want to provide a bit of an overview before we really jump in. So Aubrey, could you take us to the next slide here? So I'm going to start with defining disability. And now defining disability is complex and definitions certainly vary. But the American with Disabilities Act broadly defines disability as any physical or mental impairment that substantially limits one or more major life activities. In addition, the American Community Survey includes 6 categories of disability, which are hearing difficulty, vision difficulty, cognitive difficulty, ambulatory difficulty, self-care difficulty, or independent living difficulty. And as I said, there are lots of different definitions, so these are just 2, and eligibility for a lot of public benefits can rely on different standards. The Social Security disability insurance requires that an impairment meet their own strict list of medical conditions and requires that they are severe and long-lasting enough to really prevent someone from working. But according to these definitions, and CDC data report that 61 million adults in the US, or 26% of people, are living with a disability. So they are very common in the US. And despite that, people with disabilities face a lot of structural barriers that increase their likelihood of experiencing poverty and in turn housing insecurity and homelessness. We can talk about lower educational attainment. People often face barriers to education and can be excluded from the system a lot. People with disabilities are twice as likely to have less than a high school level of education when compared to the general population. And less of education makes it harder to access a lot of other things in life, like employment. 71% of people with a disability who are unemployed reported a barrier to unemployment. So a lot of structural barriers that make it difficult and can exacerbate a lot of conditions. Thank you, Aubrey. So we look at the link between disability and poverty. Like I said, it can limit a lot of the opportunities, like we mentioned on the previous slide, and impacts one's ability to really participate in society in many ways that come with economic hardship. We talk about barriers to employment, education. We also talk about how it can lead to reduced earnings or job loss, and it can also impose extra costs on people. And because of that, we talk about disability as both a cause and consequence of poverty. Once people are in poverty, it does make it harder to treat these disabling conditions, and these factors really reinforce each other. Because of this, people with disabilities experience poverty at significantly higher rates, and the poverty rate for adults with disabilities is more than twice that of people without disabilities in the US. Programs are offered to help people, including the supplemental security income, which out of the 7.6 million recipients that received it in 2022, or that will receive it in 2022, 6.42 million of them have a disability. So that is a significant program and a significant resource. However, it does not do enough, and benefits only make up 3/4 of the federal poverty line. So even if you are on these benefits, you're not making enough to be considered over the poverty line. In fact, in a lot of areas, it isn't even enough to pay a full month's rent. So while these help a lot to get people out of extreme poverty, it doesn't exactly alleviate all of the issues. And there's a quotation from a 2019 report from the National Disability Institute that I wanted to share on how these two things closely interact but are treated separately. While disability and poverty have an interactive effect, our social system treats them separately. For example, disability benefits, including health coverage, are often hinged on proving one is incapable of work, but anti-poverty programs often have a work requirement. Thus, people with disabilities attempting to avoid poverty often face difficult choices. So again, here's how these things are linked, but we actually treat them as separate issues in a lot of ways. Obviously, all of this is taking place in the context of an affordable housing crisis that really exacerbate everyone's risk of housing instability and homelessness, but particularly for people living with disabilities. And as rents continue to climb in the US, many renters' wages remain insufficient to afford decent rental housing. In no state, metropolitan area, or county in the US can a worker or earning the federal or prevailing state or local minimum wage afford a modest 2-bedroom rental home at fair market rent. I know that sounds confusing. Basically, what it means is that there's nowhere in the US where if you are earning minimum wage, you can afford modest housing. To do that, you would have to work 92 hours a week at minimum wage, which amounts to about 2.3 full-time jobs. So again, this is really more than people are able to afford, especially low-income earners. The wage that is required to afford a modest 2-bedroom is about $25.82 per hour nationally, and $28.94 in Colorado, which is the 8th most expensive state in the country, having moved up from 9th most expensive last year. And this is particularly, like I said, particularly difficult for people who are living with disabilities. In the US, 7 million renters with disabilities are cost burden, of which 4 million are severely cost burden. Now, cost burden means that people are spending more than 30% of their income on rent. And severe cost burden is when you get over half. And this is the point where people start to have to make really difficult financial choices between whether they want to pay for rent, whether they want to pay for food, childcare, health services, any other of the basic necessities that people need to get by in life. So cost burden is one of the things that we find really leads to homelessness when you're really on the edge there and you have to pay rent before you're able to pay costs, and you can get medical bills or anything like that. Any unexpected changes in rent or health situations can push people towards homelessness. And because we're in Colorado, 62,000 renters in Colorado are severely cost burdened and live in low income households. In addition, I mentioned the SSI. The federal monthly SSI payment is $841 for an individual and $1,261 for a couple. Again, this is well under the monthly rent price. So people who are living with disabilities relying on SSI are not able to afford either 1-bedroom studio or 2-bedroom rentals. Next, we're going to talk about how this all relates to housing instability. And when I talk about instability, I'm talking about housing that is expensive or unaffordable, that can be inaccessible or of bad quality, precarious and unstable, and also a lot of the discrimination that people face in trying to access housing. Like I said, spending a large amount of income on rent forces households to make really difficult choices about how to allocate their money, and people often have to choose between basic needs. This is particularly the case, again, for people living with disabilities, and we find that households with people who need long-term support and care services are nearly twice as likely to spend over half of their income on rent. Half of the income on rent is a very large number. Once you're spending that money, considered, again, severely cost burden, and your likelihood of experiencing homelessness really rises. And in addition, renters with disabilities report lower confidence in their ability to pay rent and avoid evictions. So they report that they are more likely to face eviction in the coming months. They report being behind, that they can't get caught up on rent, or that they will have a lot of trouble paying rent in the future. So all of this instability and insecurity is particularly challenging for people living with disabilities. In addition, we find that even housing that is accessible, although most housing is not, it can be inaccessible, lack accommodations, or is of poor quality. The housing that is accessible can be, low, like worse conditions. We talk about leaky roofs, damaged walls or ceilings, broken appliances, faulty plumbing, electricity. All of these things are things that landlords are required to take care of, but often do not. And because of that, 55% of complaints of housing discrimination were based on disability, which is twice the rate of any other protected class. So we find large-scale discrimination on the basis of housing on disability. And lastly, which is what we're talking about mainly, is homelessness. So I just wanted to give intro on how we tie this all into homelessness, but people with disabilities experience high rates of housing instability and homelessness in the United States. And we find that this has been rising over the past few years. So over a quarter of all homeless individuals in 2020, I believe, were chronically homeless. And when we talk about chronic homelessness, we're talking about people who experience prolonged or repeated stints of homelessness while also living with a disability. So therefore, this definition of chronic homelessness incorporates, by definition, people with disabilities, but it doesn't incorporate everyone. There could be a lot of people who are living with disabilities and are homeless, but not with that repeated or prolonged part of the definition. And chronic homelessness has really been on the rise in the US in the last few years. In Colorado, there were 2,954 people experiencing chronic homelessness, which was 30% of the total homeless population. And between 2007 and 2021, chronic homelessness increased by 6% nationally, but astonishing 265.8% in Colorado. So again, this is the kind of homelessness that we see, particularly among people who are unsheltered. It's most visible to people who are bouncing around between shelters or who are caught up in sweeps very often. And Colorado saw a 34.6% increase just between 2019 and 2020. So this has really, really been on the rise in recent years. one thing I'd like to point out in doing a lot of this research, I also am working on a disability and homelessness brief that we will be publishing in the next few weeks. But there's not a lot of great data out there. A lot of the continuums of care that collect this data on homeless people and homeless populations don't ask specifically about disability and disabling conditions. One that did was the Colorado Balance of State Continuum of Care, which addresses the non-metro regions. And they found that about 75% of respondents list at least one disabling condition. And that was in the year 2021. So there's a bit of an overview. I could turn it over to our panelists now. I'm sure they have more interesting things to say. And yeah, thank you guys.
Thanks, Andrew. So yeah, to everyone who was on the journey with us about the chat, I'm glad it's working now. We apologize for having our settings wrong, but so glad that folks are able to chat with each other now. And then please do continue to use the Q&A box to ask questions for our panelists. So I'm going to go ahead and introduce our panelists who are here today. I believe we're still waiting for Dr. Julie Nockel. So we're going to go ahead and get started with who we have. And then if Shannon and Andrew and Aubrey, if you can be on the lookout for Dr. Nockel to come in, if you can just
I'm here.
update.
I'm here. I've arrived.
Oh, yay. Okay.
I can't turn my video on. I'm not sure why, but I'm here.
We're having a fun time with our settings today. So Shannon, can you help Dr. Nockel with her video? That'd be awesome. Great. So I'm going to go ahead and introduce our panelists and then we'll get started. So first, I would love to introduce Dawn Howard, MLS, the Community Engagement Coordinator for the Colorado Cross Disability Coalition. Prior to her current position, she worked in public libraries as a librarian in both Colorado and Florida. She lives with alopecia, believing bald is beautiful. In her free time, she walks, spends time with friends and family, attends live music concerts, and writes poetry. So, hi, Dawn. Awesome. Dr. Julie Nockel, MD, was born and raised in Aurora, Colorado, and has been proud to complete her undergraduate and medical school training close to home at Colorado State University and University of Colorado School of Medicine, respectively. Since completing her training in internal medicine in 2016 and joining faculty as an assistant professor of medicine at the University of Colorado School of Medicine, she has practiced hospital medicine at Denver Health Hospital. Her clinical work inspires her academic interests, which include research exploring how people experiencing homelessness access and interact with healthcare services. So welcome, Dr. Nockel. And will you tell me if it's Nockel or Nockel?
It's Nockel, like knock on the door.
Yeah. Knock on the door. Perfect. Thank you. And finally, Mariah Nunnally, RN, is the Director of Recuperative Care at Colorado Coalition for the Homeless, focused on helping open our new 75-bed recuperative care program this fall. She's currently pursuing her MSN with a focus on informatics and data. She has experience in hospice, psychiatric nursing, and in IT operations in a prior pre-nursing career. Her hobbies include rock climbing, cooking, and hanging out with Owen, her 13-year-old lab. So welcome, Mariah. Awesome. All right. So let's see. Let me just make sure that we have our settings okay and Dr. Nockel visible. Okay, great. Okay, awesome. And then Andrew, can I request that you turn off your video just so we only have our panelists visible? Thank you. All right, so welcome everyone. Thank you so much for joining us today. The first thing I want to do is kick off. I just want to give everyone a chance to comment on the short presentation that the lovely Andrew gave. As he said, we're, not all data. It's not perfect data. We know there's a lot of missing gaps. What's missing? Is there anything you'd like to add? Is there anything you'd like to correct that you think it doesn't represent the data well? And I open it up to anyone.
I kind of want to point out to all of us as it's 2022 and we all live in more of a data-driven world, that the fact that there's such little data about unhoused populations, particularly kind of related to long-term studies, should help reinforce how difficult the life that those individuals live. It's so hard to even kind of access individuals sometimes that are unhoused for data, that I think it's just a reinforcement of this issue we're all kind of trying to solve together. And whenever I look for a peer-reviewed journal article related to something I'm interested in and it doesn't exist, I'm like, well, of course it doesn't exist. We can't call people that don't have a phone, and we can't find people that don't have housing. So it's just kind of a part of the cycle of problem we're all trying to kind of solve.
Thing that I like to point out is that even those who are on SSDI, who have worked more than 10 years and then become disabled, the average in 2022 is 1358. So, I mean, we talk about 841 for people who haven't worked more than 10 years. But if you're trying to live in Colorado on $13.58 a month, it would be really hard. And we are talking about people, real people. So data can capture some of it, but it really cannot capture real lives and the real struggles.
I think just really bouncing off of what has already been said, the doing reflection in preparing for this panel, I think to myself, how often am I really even understanding whether perceived disability is present in a patient I may be seeing? I don't even know that I could categorize it intersecting with our known or my higher comfort level of knowing that we can't accurately understand housing status. And so I think two identities, I'm just so struck by the intersection of two identities that are particularly hard to capture accurately for research and numbers. And so I agree, I'm not surprised by the overall paucity of kind of data, and I wouldn't be surprised if it could be better studied, if we would all be blown away by the intersection between the two experiences. But I don't have any corrections because I don't have any additional data.
Thank you all for those answers. And Dawn, I think to your point, that first section where we concentrate on data is really far from being person-centered. And, we know that the terms disability and disabled are complicated to define and really differ from person to person. So, as our representative from the Colorado Cross Disability Coalition, which is an amazing organization and you should all look up and look how to advocate with, can you sort of explain the terms and why self-identification is important, or tell us what we're missing in terms of the personal perspective that maybe we haven't covered yet?
So disability includes people with all kinds of disabilities, hidden, visible, people who are elderly can be disabled too. They may not refer to themselves as being disabled, but if you walk with a walker or use a wheelchair, you do. And at CCDC, we often talk about disability pride. I'm a disabled woman. That's nothing to be hidden. we think about abilities. So yes, the ADA, we use around CCDC the ADA definition of substantially limiting activities of daily living, but you really have to talk to the person. People will and understand that people with all kinds of disabilities will react differently. So it's people, individual. So yeah, and understanding that many disabling conditions have a range. I'm a person with cerebral palsy, and there's a huge range of people with cerebral palsy. It's autism, muscular dystrophy, multiple sclerosis, you name it. There's a whole range.
Thank you, Dawn. So this question sort of for anyone, and as Dawn said, there's such a huge range of folks to cover. Please know it's a broad question, and we're not going to be able to fully answer it. But can anyone speak to some of the ways, some of the unique considerations and difficulties for people experiencing homelessness who also have physical and mental disabilities, especially when it comes to folks who are unsheltered, and just sort of the uniqueness of trying to navigate both of those identities at the same time?
So in my work, I care for hospitalized patients, all hospitalized patients, but I know that I care for about a third of the patients I care for are unhoused. And I know that because I ask and try to understand. I honestly don't have a real clear sense of how many people I care for who have disabilities, but my sense is that it is perhaps almost all. It's very high and honestly something that perhaps I don't think about a lot outside of if it's really pertinent to what I'm treating them for, which may have nothing to do with the disability. But there's, I think, a high perception. So a high intersection. And so while I don't have lived experience, which I very much acknowledge, I have accumulated experience in encountering a multitude of scenarios involving unsheltered people who have limitations, and again, in my mind, perhaps I don't call them disabilities, but that is like what Don was saying, that is what they are, people who need mobility aids for any reason. So I have a multitude of experiences. I mean, I think there's so many barriers that it can be really daunting and heartbreaking. Just access to mobility aids and stability of that is problematic in terms of our ability to maybe supply high quality mobility aids is one thing. And then replacement, if they are lost, stolen, or broken, which is very real and very common. And those are kind of limitations. That's one thing that kind of comes to mind. I think a lot about providing care for someone who is either, if they may be chronically homeless, but newly disabled. That's a real challenge. And there's, frankly, not adequate resources present in our community to kind of navigate that nuance of what someone may really need to be successful. So new disability is a real challenge. I think aging into disability is something we are more comfortable with, and is something that societally more broad, but it's really challenging in a population where maybe someone navigated the shelter system in the past, or navigated being unsheltered in the past better, but is no longer able to do that. And I think we hear a lot of that, like, slow slide into no longer able to tolerate things that I used to. And so I'll leave it at that. I think there's so many unique scenarios that are really challenging. And I think the question is really about kind of what are the unique scenarios, and they're so unique. I think there's so many. I'm blown away by how often sometimes you think like, oh, maybe I've seen it all. I've seen all the predicaments that we can as a society bring forth, and really like a combination of challenges to benefits or challenges to needed care. I think it's never ending, the challenges we see, which makes it hard to be an asset-based person, which I think is all of our goal, because I'm talking a lot about deficits here. And I wish it were different, but I think sometimes we're put in a place where we are really asked to solve deficits.
Mariah, I see you doing a lot of nodding. I didn't know if you wanted to add in.
I've probably taken some of Julie's referrals, just thinking about recuperative care. I think before I got into public health, and then particularly with the unhoused, and then even recuperative care, I had this idea in my head that if someone was disabled or had a disability, they had access to things that they needed to survive. And that's just not the case. Individuals, DME equipment, right, for ambulation, wheelchairs, walkers, things like that can get stolen. It's not like you can, Medicaid doesn't just pay for someone to keep getting another wheelchair. I was on outreach actually a few weeks ago, and the first gentleman we saw had both feet amputated, and someone stole his wheelchair. And I just remember thinking we had to scramble and find a wheelchair from somewhere else. And it's very common, things like this. And those are kind of traditional ambulation disability we think of. But I think of a gentleman we had in our protective action motel that was newly blind and was trying to navigate getting through the world, newly blind, without eyesight, with very little resources available, because not everyone has access to the insurance they need for even treating a disability. And then, there are such few resources in the community for the unhoused. If you, getting fitted for prosthesis basically is very difficult to do. So you'll see individuals without limbs kind of moving around in the community, and they probably just never had access to even get support for that. And then I think if we also thinking about disability more broadly, there are individuals that have mental health and behavioral health disability, and living on the street is really hard with that as well. There's no resources for them. And then streets can be very hard places to live. And so if you already have a challenge kind of with mental health or behavioral health, trying to fit into a really kind of sometimes dangerous environment, I think can be very challenging as well.
Thanks, Mariah. And I'll just add in quickly, for folks who aren't maybe haven't attended one of these sessions or don't have as much knowledge of people experiencing homelessness. When Mariah says that it's unsafe, we know that people experiencing homelessness are more often victims of crime than other individuals. So that's why
it's not unsafe because of the unhoused individuals. It's unsafe. They get attacked violently. They get swept violently without notification. They are targeted. There are people that target the unhoused for verbal abuse to physical abuse. It's really disheartening, actually. And so the more vulnerable someone is on the street, the more likely they are to be a victim of that. But yeah, statistically, our folks we work with are actually significantly more likely to be the victim of a violent crime and then be the perpetrator. And it's really sad because they're already struggling to survive, and then they also have to worry about their own safety on the street. So thank you. Sorry,
No, I wasn't.
sometimes forget. Not everyone probably is as familiar with the data as I am. So thanks for also throwing that in. But yeah, the streets are unsafe for our unhoused people, which is why we should all want them to get off of the streets and put them into permanent supportive housing options.
I would like to add a few things. People who are deaf, English is the, and no American Sign Language. English is the second language. So it's really important to think that through, to not discard emails with rudimentary language because it's a second language. Transportation is difficult. It's such a ride. You can ride for 2 hours to go 20 minutes. RTD can be late. So appointments, think about that. Doctor's appointments, people can try their hardest to be on time, but if the bus sets right, it's late, it's really not their fault. Sometimes the best problem solver is the person themselves. They may know what to do or how to solve the problem. We need to listen to them. We need to make sure that all information is as accessible as can be on websites. And with people with complex needs, it's often very helpful to have a team of people to look at all the problems at different angles. And CCDC can provide some recommendations.
Thank you, Dawn. Those are such wonderful, thoughtful, specific examples of ways that some folks aren't necessarily framing, someone being late to an appointment or anything like that. And it's really great to have those exact examples. Dr. Knuckles, you have.
Can I add one more?
No, please. I think
Okay.
this is why a lot of people come to these sessions, is to really learn how do we actually help folks. And so, yeah, any practical solutions you have, please throw them out.
Yeah, I think just two things that popped up while I was listening, one, it was from the chat, this kind of question of lost wheelchairs and things. And it's absolutely, sometimes we hospitalize people with the plan of finding their wheelchair, if people are not able to navigate the community without it. And so, of course, that's not an appropriate or ideal use of healthcare utilization. But it's real. And another anecdote that Mariah made me think of is a gentleman I cared for also with visual impairment, who had the right benefits, had actually home and community-based services and had a caregiver, did not have a home because of, probably inadequate access to rental aid and eviction protection. And so when you have the things, when you have the caregiver and you have that aid, but you don't have a home to have that care delivered in, it's really kind of that intersection of just you can get all of the things that you're eligible for, and which is actually pretty amazing to see people when people actually have the benefits they're eligible for. That's great, but without a home, without a place for those services to be delivered, it still creates fundamental problems, and that's really, I think, what's so really intriguing to some degree, but also these identities have some real core challenges when they come together, depending on the severity.
Thank you. So next question. So COVID-19 has obviously had and continues to have a huge impact on how we live and access care. For people living with disabilities, how has the pandemic affected their ability to access healthcare and housing safely? And especially for those experiencing homelessness. I don't know if folks have perspective on that. And we also know that we're still in the midst of it. And, it's part of the reason that these are happening remotely. And so, please know that this is it's not a past tense question.
Well, I think one of the things I think about with our unhoused individuals that are also living with a disability, Don mentioned transportation, and someone that's immunocompromised taking RTD or public transportation, particularly in an economic situation where more folks are losing their jobs, more individuals are becoming unhoused, like there's an economic issue that's occurring, it puts them more at risk, right, of these infectious diseases like COVID or monkeypox or any other infectious disease. And it keeps, they're already more immunocompromised, and now they also have more exposure to these viruses. And I mean, COVID-19 was really scary for us at the beginning of the pandemic. I think we all thought the population we worked with was really going to really get sick. And that's why we worked with a lot of community partners in the city to get folks into different types of motel situations and whatnot. But these infectious disease kind of issues that I think house people take is for kind of granted right now that it's starting to end, do not end for our unhoused neighbors. They don't have an ability to safely isolate. You can't isolate easily on the street, and you can't isolate in shelters or congregate spaces. So I think it's actually drawn a lot of attention to the kind of plight unhoused individuals deal with kind of in congregate settings or on the street. It not only makes them sicker, but it also makes our community sicker, right? It's just, it just makes the issue worse when we don't have the right resources for individuals to get housing.
When I think about the value that investment in protective action and our ability to, temper, and Mariah may know more about some of the specifics, but the value that came from providing shelter to more high risk people experiencing homelessness, that was really, I think we saw a lot of things that went well from that, and that's the challenge is now what is the plan? But I do think there's value. The other thing I'll comment on is, obviously during periods of the pandemic, there were significant restrictions on visitors in hospitals, and that has disproportionate effects on some with, in my mind, people with disabilities greater than others. And so in some instances, and I think that's a place where there have been lessons learned, I think, from what has happened, but that was probably a place where people with disabilities were maybe disproportionately isolated and had unequal kind of access to the care that they needed.
I think for people with multiple disabilities, we have to remember that for some of them, COVID isn't over, and I'm sure that there is a lot of fear as people relax, as areas get more crowded, how do they take care of themselves?
Thank you, Dawn. So as we saw in the data at the beginning, disability is both the cause and consequence of poverty, with poverty being a major contributor to homelessness. For people who are low income and maybe unable to afford health treatments they need or housing opportunities, where can they go in Denver and in Colorado if folks have sort of resources to recommend?
Well, Colorado Coalition for the Homeless has amazing primary care. We're a federally qualified health center. We have a main clinic. We have multiple other satellite clinics. Denver Health has some clinics as well. They also provide amazing care. There are other local clinics in the community too, right? That, I mean, we all work together, right? This is not, there is no sandbox issue, I guess. And I think that COVID even really showed that more. Stride, there are multiple clinics, there are multiple ways to access care. I think the challenge is folks getting to their appointment, transportation, them understanding how to make an appointment. It's kind of the navigation of access. It's usually the challenge. But yeah, there are multiple places to get primary care, of course, which is the more upstream we can provide care, the better for folks. And then, usually once they get tied into a primary care provider somewhere, they'll be able to access specialty care that they need and other kind of medical and clinical resources for more specialized needs.
I'll just briefly say, in addition, the one place that's associated with Denver Health now is the Shonda Center for Health, which is a really, really beautiful clinic designed very intentionally and is very accessible to people in wheelchairs. And from my view, I went and toured it and checked it out a few years ago. And so that's a specific resource, but I think there's just, I remember asking about like, but how could you possibly meet the need with this? And I think that's the answer is kind of the tailored care maybe is not fully available, but that's one place, that one place that I was really impressed by the commitment to it.
Housing is a huge problem. Every week, I have people saying, I need to move in a week. And I feel like the list that I email are pretty, they are inadequate because I don't have vouchers. I don't have buildings that will take vouchers. I have to dampen expectations and say it'll take maybe 18, 24 months. And it's really hard.
That's, a good lead into the next question, which is that just the shortage of accessible housing, and that even when folks are qualified and have their voucher, and there isn't affordable and accessible housing. So statistically, we have 65,528 homes for 127,139 households with disabilities. And then, as Andrew mentioned in the intro, of the limited housing that we have, much of it is inaccessible, it lacks accommodations, or it's of poor quality. And so how, I think I think it's unfortunately, it's like there's only so much that all of these organizations can do when we have half of the housing that we need for the people. But in terms of those of us who work in advocacy and any sort of solutions that you all have, you know, what can we do to ensure more accessible housing is available in Denver and Colorado? And are there any existing protections for people with disabilities seeking accessible housing that people should know about to prevent homelessness if they're maybe being discriminated against in their current housing?
One thing that we really encourage is universal design. So, so buildings that incorporate features that make any unit as adaptable. So it costs hundreds instead of thousands to adapt. Because we are a minority group that anybody can join at any time. And yeah, so that's one thing that needs to be pushed. It costs a few $1,000s more per unit. But it's worth it because we never know who will be born into disability, age into disability, have an accident.
This absolutely comes up at the hospital level of people requiring our services, not because of an acute illness, but because of newly inadequate housing and ability to navigate that. And so that's a big reason for interaction with kind of acute healthcare is structural inadequacy of the environment. And so I just, that's absolutely, I love that statement. Anyone can join at any time. And that's so true. And we see the ramifications of that in a very costly way.
Yeah, Dawn, I've never heard that. And I have to say that, like, that took my breath away, that comment. I mean, wow, what a reminder for everyone of why we should all be invested in it because it's the right thing to do. But I mean, yes, like that is a true reminder of, and it can literally affect any of us at any time. It's really impactful.
If people are on Medicaid, there's with some of, depending on the Medicaid, there it can be some home modification dollars, but I won't go into the specifics. It's worth asking about.
I was hoping to see some of our local representatives on here also. I think also, right, being during election time, we need to elect individuals that will fight for our local communities so that we can use local and state dollars for things. Like Dawn mentioned, I got to see the new building earlier again, and I'm really proud that we built affordable housing. We're building some new affordable housing, and all of the units are able to be converted to ADA accommodating spaces. But the legalities around that are pretty abysmal with the requirements. And so I think us electing representation and then demanding accountability for that at the local, state, and federal level to get laws enacted and changed that require new buildings to be built in certain ways. You know, more than 5% of them should be compliant for needs that identify as living with a disability. And I think getting some local and state tax dollars behind it as well, and us all realizing that this is a man-made problem, so humans have to fix this, and so we all have to be invested in our community and advocate for affordable housing to be built near us and built properly. So I think just remembering that we all need to be advocates and loud advocates with the people that we're having represent us on all different levels, so that we can get some more change made.
One real quick thing, thinking about the kind of comment of we're a minority that Don said, I'd actually just introduce one idea. I think within the community of people experiencing homelessness, and again, the numbers are shaky, but the things I'm familiar with in our personal kind of surveying in the hospital is that perhaps that's not going to be true soon. And within this may be a majority of people with experiencing homelessness with a disability. And so the intersection of that may actually become like a majority of our unhoused community may actually identify. So it may be a majority minority kind of scenario, which should really push the advocacy efforts further if that data and kind of delineation and definition component can get there. So I think as a physician, thinking about, you need the numbers to convince people in this world. And so I think when you say, look, when we're talking about, we obviously need to build more affordable housing, but actually we need all of it. Like we're saying, it's not just that like it should be because of the law, but it actually needs to all work because of the makeup of our aging population. So that's, I don't know, I'm just throwing that out there.
Thank you. And I think it's interesting, being the minority, even if people with disabilities are the majority within people experiencing homelessness, people with disabilities are still a minority population that we know is not getting the right amount of funding. Neither people with disabilities nor people experiencing homelessness get the type of services, funding, attention, and they don't get their needs met. And so, I think it's really hard because even if those folks become the majority within the minority, we're still structurally just not at all having needs met. And that's unfortunately, I think, what we've seen. And I think substantial transformative change would be necessary in order to meet the needs we currently have, let alone those that we're going to be having in the future, right?
And we must understand that you put other minorities, all of the ethnic people of color have a higher percentage of people with disabilities, and probably a higher percentage of people experiencing disabilities are people of color.
Absolutely. Thank you, Dawn. And we know that those numbers for people experiencing homelessness are disproportionate for people of color. And that's not something that we were able to cover in the data, but I hope that when we have our longer report that we're able to dive into that more. I'm going to sort of start to move us towards Q&A from folks who are attending. There's a Q&A box if folks want to add it in. One thing I wanted to do before I do that was, Mariah, we've talked a little bit about the new building, but I'm going to just explain a little bit about it, but then you can correct me because you work directly with it. But it's for folks who don't know, the Colorado Coalition for the Homeless has 20 buildings that we have with about 2,000 units that are available for people experiencing homelessness on any given night are housed in our buildings, and another 2,000 with vouchers through us. And we have a new building coming up next month, and next month or early the next month. And we're really excited. It's going to have 98 units of housing, as well as 75 beds for the Recuperative Care Center on the first 3 floors. So I just want to first say that we're incredibly excited, and this is a huge deal. And also it takes years to build a building with 98 units. And this is where no matter how amazing our organizations are here in Denver and Colorado, and that's not to toot our own horn, that's everyone that we work with to make these big projects happen. It's just never enough to keep up if we're not getting that broader investment. But Mariah, if you in particular could talk about sort of what it means to have a recuperative care center on the first 3 floors, and sort of the gap that fills for some of our people experiencing homelessness, and sort of what we're doing with that, just because I don't want to breeze past it, because I know we talk about it all the time, but make sure that everyone knows what we mean.
Yeah, I was excited to join the panel for this. It's going to be a gap filling part of our system. And there's this huge part of me that's also sad whenever I talk about this, because the huge gap is still going to exist. Definitely putting a dent in it. Like Alexis mentioned, it's the only building of its kind in the nation. It's going to mix permanent supportive housing with a recuperative care center that is a really niche part of healthcare for the unhoused. And basically, it's if a housed individual went to the hospital and they met discharge criteria and they had a home to discharge to, that's where they would go. Most of us on this call have probably been hospitalized before or know someone, one of our loved ones, perhaps. If you're unhoused and you go to the hospital, and Julie's trying to talk to her social worker about where to discharge me if I'm unhoused. Sometimes I can't go to the street or shelter sometimes that will undo the work. It'll exacerbate an issue. Sometimes people have medications that they need access to that you can't easily hold on to on the street or in a shelter. And so recuperative care is a short-term program that is for usually individuals coming from a hospital. Sometimes we send our own folks there so they don't have to go see Julie or Dr. Stella at Denver Health, to try to make sure we're helping keep our healthcare systems running the way they should, right, without individuals that don't need that level of care. So we'll be getting referrals from the community hospital partners and holding on to folks for probably a 4 to 6, maybe longer, depending on their need, length of stay. And we're ideally going to be able to support some people that right now there's no resource for. So individuals that need longer term rehabilitation after they go to their short-term rehab. They might need a place to get fitted for prosthetics, PT, OT, hospice. Hospice for the unhoused is almost impossible right now. There's a really great shelter-based program that has 2 beds, Rocky Mountain Refuge. But outside of that, it's really awful to die in a shelter or on the street if you don't want to, and there's no resources for that. So individuals that need chemotherapy or radiation don't really have anywhere to stay safe, or some of our folks are on dialysis 3 times a week and they don't have a place to stay so that they can safely get to those appointments while they're trying to work through kidney failure. So going to be filling a gap. I'm really excited about it. And our gap is going to continue to exist. So again, I think that advocacy piece of if this is our community, it's all our shared community. Our unhoused neighbors, our neighbors living with a disability are our community. And so we've got to take care of each other better, so that we're all healthy in the community that we all live in.
Thank you, Maria. Dr. Knuckle, did you?
Yeah, we're so excited. It is such our current, access to respite is present, an incredibly important component of this kind of care continuum that I think sometimes people kind of gloss over a little bit. And I think it's really been underdeveloped with an over-reliance on acute healthcare utilization. And I think it's really, really exciting to see us moving towards this model of really necessary care for kind of healing and recuperation. And it's really exciting. We're going to need more of it though. So, but it's a great step.
I will be calling you.
You have an open invitation anytime, Dawn. I was going to send that in an email, but now I've said it in person in front of a lot of people. So open invitation anytime, Dawn.
Great. So I'm going to go to a question from the chat from Diane Reinhardt. Says, is it true that there are accessible shelters, but the disabled person cannot get transportation to the shelters?
I think it depends on what definition of accessible you're talking about. There are newer shelters that are definitely more accessible for kind of mobility challenges. There's actually not many shelters that if someone has like multiple chronic conditions and a disability and they're on oxygen is very difficult in the Denver area for shelters to accommodate safely. And yeah, sometimes individuals literally can't get the transportation they need to get to a shelter. Usually the hospitals get individuals there, but if someone's not coming directly from a hospital, transportation can be challenging. Lifts and cabs don't always accommodate wheelchairs, or in fact, very few of them actually do. And accessoride and teleride options can be really challenging for unhoused individuals because they don't have a phone, right? And it's hard for someone without a phone or housing. So you might hear Owen scratching the floor. It's hard for someone without a phone or housing to be able to access teleride or accessoride sometimes, because you have to call in advance and it can be very challenging to get to the shelters.
I know that I don't know about, I would imagine transportation is a huge barrier. People need to be accommodated if they have long-term supports and services. Service dogs have to be accommodated in shelters too. But finding truly accessible shelters is a real struggle.
Thank you. We have a question. Will the new build include transportation services? Colorado Coalition MedCab says.
So yeah, we partner with our hospital partners to get individuals over, and then we do usually have we have a Lyft account. There are multiple ways we end up getting individuals to the new building, and one of the components of recuperative care is getting individuals to specialty follow-up appointments. So I'm hoping eventually we can buy a van or something, but I think that'll be down the road. But we do definitely provide transportation services.
Great, thank you. I don't think this is an answerable question, but it was sort of in the, it was in one of our people before the session started had sent it in, but it says, what is the most common disability people experiencing homelessness have? I don't think that's at all answerable, but perhaps, when we're talking about mental and physical disabilities and cognitive disabilities and different types, is there anything that folks can speak to?
I think it's so hard, right? Because it kind of also depends on, are we talking about self-identification? And then there's also other things that come into play with disability, like individual racist structure. Actually, individuals that are BIPOC are much less likely to have a diagnosed disability than a white counterpart with the same issues. And so that even goes into play of like rapid rehousing or vulnerability index that are like most things in life, systemically oppressive to more vulnerable populations. I do know, so I don't know the answer to that question, but I will say maybe something that the question asker would be interested in is that TBI is the data behind about 1/3 of individuals that are unhoused, chronically unhoused, having either a diagnosed or undiagnosed TBI, I think is a really poignant thing for us to all think about when we think about some of the challenges between the cross-sectionality of disability and homelessness, is that our population has a lot of trauma and a lot of challenges sometimes with even being able to kind of maneuver through the world with their brain. If 1 in 3 people, their brain is not working as well as it could be without that issue. So I always find that to be an interesting kind of data point to think about.
Yeah, I think that's an unanswerable, because I think that the question, like Maria was saying, it's how do you know when you don't maybe have a stable longitudinal relationship with a person? How do you know? You don't know. And I think so then like the self-perceived is obviously really important. I know when we did I can offer this, which again might be helpful, but doesn't answer the question. When we tried to answer the question of how many people are experiencing housing insecurity in the hospital at a single point in time, we did ask about like self-diagnosed kind of physical disability. Do you identify as having a physical disability? And half did, which I think is fairly in line with any literature of, really pretty high rates. But that being said, I think there's also in the realm of 30 to 40% at least around substance use disorders or substance use, and then similar for mental health. And, some of those things are overlapping. And so I think there's several that are fairly high, and it would be really hard to know further. I think also mobility is something that is common because of the experience of homelessness and the hardship to the body. So that's one that can be really clearly linked as developing related to it. Violence, trauma, TBI, that I think we do a really poor job of identifying.
Thank you. I think we're heading to the end of our time. So if any of you have anything you'd like to say at the end, please don't feel like you must, but if you have anything, any sort of final thoughts or anything we didn't cover, anything to say, and then once we've done that, I'll pass it to Aubrey to close. Okay, everyone's still muted, so I'm going to take that as a sign. Oh, Dawn?
I would just ask you to think hard as we go into election season. I will repeat what Mara said: vote. Think carefully about how you vote for real people living in poverty and homelessness with disabilities. They are people.
Thank you so much, Dawn. Aubrey, I'll pass it to you.
Thanks very much. And thank you for all of this amazing conversation tonight. Dawn, that was a really great note to leave us with. And with that, that's a great transition to my call to action to join our advocacy network at the Colorado Coalition for the Homeless. Right now, we are deep in our voter registration drive, trying to make sure that folks who maybe had no idea that they could vote without an address are able to do so. Also, folks with criminal records are, for the most part, able to vote in Colorado. So we're really trying to dispel those myths and make sure people are able to take this first advocacy step and get engaged. But other than voter registration, our advocacy network is a group of community members, CCH staff, and clients who help inform some of the policies that we work on. To Dawn's point earlier today, we want to make sure that folks who are living with disabilities and are living at the intersections of many of these identities and experiences are at the table and creating policy and creating change. So this is a space to do that. I encourage everybody to visit this link here or reach out to me directly by email and I can get you involved. We also have a really exciting project coming up, the Denver Basic Income Project that CCH is partnering on. So this will provide folks with a basic income to hopefully get housed and meet some other basic needs. And we need help with application and enrollment. So I would love for folks on the call to reach out and see how you can get involved in that. I also want to share this opportunity to learn a little bit more about the intersection of housing and all of these identities and experiences we've talked about tonight. Dawn is one of the stars of this short documentary screening. It's only about 35 minutes long and it will be followed by a short panel discussion. This documentary tackles the way that housing is the foundation of strong families and thriving communities through the lens of disability, LGBTQ rights, the different racial identities, workforce issues, health, and the list goes on. So I'm really excited for this, and I hope you all will join. And somebody, I think, will be able to drop that registration link in the chat there. And with that, I will turn it back to Alexis.
Thanks, Aubrey. Yeah, just wanted to let folks know about those 3 upcoming dates. We do have those locked in. So for September 15th, we'll be doing another one of these sessions on families experiencing homelessness. How can the response system adapt? Then on October 20th, we're going to have a session on affordable housing and the homelessness crisis. What is the state doing? And I'm sure we will talk at that point about any upcoming ballot measures or information that would be helpful regarding that. And then in November 17th, we want to talk about winter homelessness and have a learning session for community members and really help everyone to know what we can do to assist our neighbors as the winter comes. So that's our emphasis for November. So that's all. We thank you so much for joining us. We hope to see you next month. Thank you to our amazing panelists. You guys was so wonderful, and we appreciate everyone.